Hi guys, this is Dr. Pritesh Singh, surgery faculty with PrepLadder and author of Surgery Sense, AIMS Sense, NEET Sense, quick review of surgery and INI-CET Sense. We are going to discuss the surgery questions of FMGE June 2022. These are my best-selling titles. So let's start the question. Number 1. Young female presented with 3 into 3 centimeter mass. What is the size of mass? 3 into 3 centimeter. Okay. In the left breast, the mass was freely mobile. So what are the catchy words here? Young female, size of mass 3 into 3 centimeter, and it is freely mobile. What is the most probable diagnosis? So you know that fibroadenoma is also known as breast mouse. Why it is known as breast mouse? Because it is freely mobile, and fibroadenoma is seen in young females usually. What's the age? 16 to 25 years. It is 16 to 25 years. Clear? So what is the correct answer? The correct answer is C. Let's rule out the other options. Phyllodes tumor. So what is the presentation in phyllodes tumor? Affected breast is massively enlarged. In this image you can see what? That affected breast is massively enlarged in phyllodes tumor. And if you palpate it, it is having bosculated appearance. So massively enlarged affected breast, there is bosculated appearance. If you see breast abscess, in breast abscess first there is pain, there is tenderness, patient complains of fever, and generally breast abscess is seen in lactating females. How it looks like? So here you can see there is erythema, and whenever you are going to give incision, you can see the pus coming out. These patients are having fever, these patients are having pain, these patients are having tenderness. Carcinoma breast, generally it is seen in females who are 40 plus at least. Clear? And in carcinoma breast, generally the lump is hard. It is hard. And if it is advanced malignancy, there might be involvement of skin, there might be involvement of nipple, involvement of chest wall. So you can see fixity to skin, there is nipple retraction, deviation, ulceration. Clear? So what is the correct answer here? The correct answer is fibroadenoma. So what is the presentation in fibroadenoma? Age is 15 to 25 years, young female. And why it is known as breast mouse? Because it is freely mobile. This is freely mobile. Okay. And what is the most common presentation? Patient comes with lump. It is firm and mobile. Investigation of choice for diagnosis, FNAC. In majority of cases, conservative management is advised, but if patient insists, we can go for excision of fibroadenoma. So, correct answer for this question is C, that is fibroadenoma. Question number 2. A postpartum female presented with pain and swelling in left lower quadrant of breast. So, first catchy point is postpartum female. There is pain and swelling in the left lower quadrant of breast. Simultaneously, she is having fever. And on palpation, if you put the fingers over the breast, there is increased local temperature. Fluid collection was there on ultrasound. So if ultrasound you are going to do, there is cystic collection or fluid collection. What is the treatment of choice or treatment of this condition? First, you tell me what is the diagnosis. Postpartum female, pain, swelling, there is fever, increased temperature. It means this patient is having what? Breast abscess. The patient is having breast abscess. Clear? And you know that in lactating females, there is increased risk of breast abscess. Why? Because of faulty breastfeeding technique. What happens? There is trauma around the nipple, and the Staph aureus is most common organism. In these cases, what is the treatment of choice? That is incision and drainage, and we give antibiotics also. Incision and drainage plus antibiotics also. So see the options. Conservative management? No. Ultrasound guided aspiration? No, this is not the treatment of choice. Antibiotics only? No, because pus collection is there, you have to drain it. So correct answer for this question is D. So we discussed how it looks like. You can see here, just after giving incision, what? Pus comes out. We discussed what is the most common organism responsible. That is Staph aureus. It is because of faulty breastfeeding technique. There is pain, tenderness, breast is engorged, there is erythema, there is fever and chills and rigor. Apart from incision and drainage, we have to give antibiotics. And in NEET PG, this question also asked that what is the first line agent for breast abscess? We give cloxacillin or dicloxacillin, and for how long we give 10 to 14 days. So we give cloxacillin or dicloxacillin for 10 to 14 days. See question number 3. Which of the following confers good prognosis for invasive ductal carcinoma breast? This question you can easily solve by applying principle of exclusion. So see the option number 1, high mitotic index. If a tumor is having high mitotic index, obviously there is poor prognosis. There is poor prognosis. You know, if there is overexpression of HER2 new positive receptor or HER2 new receptor, again it's poor prognosis. If there is metastasis to lymph node, again it confers poor prognosis, right? So A, C, D, these are going to confer the poor prognosis. If you're talking about mucoepidermoid carcinoma is having favorable prognosis. This is associated with favorable prognosis. Clear? So what is the correct answer? The correct answer is B, that is mucoepidermoid carcinoma. Question number 4. It's a repeat question. This question was asked many times in the exam. In a 35 years old pregnant female, she is having hyperthyroidism. Which anti-thyroid drug should be given in the first trimester? Okay, so before discussing this question, let us discuss what are the side effects associated with anti-thyroid drugs. The anti-thyroid drugs which we give, that is methimazole, carbimazole, propylthiouracil, and one of the common side effect of all these are agranulocytosis. One thing. Second, methimazole it is going to increase the risk of congenital malformations. What are those malformations? One is choanal atresia and second is aplasia cutis. That's why we avoid it in pregnancy. So we are not going to give what? Methimazole. What is the problem with propylthiouracil? That propylthiouracil is going to increase the risk of hepatic failure in females and children. There is one advantage also, that it is going to block peripheral conversion of T4 to T3. It means we should avoid giving propylthiouracil in females and children, but if there is life-threatening situation like thyrotoxic crisis, we can give propylthiouracil. Now see the questions. So what is the anti-thyroid drug of choice in Graves' disease? We give methimazole. If a patient is pregnant, we cannot use methimazole, so we give carbimazole. And in patients having thyrotoxic crisis, we give propylthiouracil. Now there is a catch. Drug of choice, anti-thyroid drug of choice in pregnancy, that is carbimazole, but if specifically it is mentioned in the question that in the first trimester, which anti-thyroid drug should be given, then the answer should be propylthiouracil. Clear? Now see the question. So pregnant female, hyperthyroidism she is suffering from, and which anti-thyroid drug should be given in first trimester? It is propylthiouracil. Imagine if trimester is not mentioned, or if it is asked in second or third trimester, then drug of choice should be carbimazole. So carbimazole is the drug of anti-thyroid drug of choice in pregnancy. Methimazole is an anti-thyroid drug of choice in Graves' disease, and for thyrotoxic crisis it is propylthiouracil. And if it is asked for the first trimester, if you want to use, which one should be preferred? It is propylthiouracil. So correct answer is C. Question number 5. A 50 years old male patient presents with palpitations, episodic headache and sweating episodes. Tell me, these are the characteristic symptoms of which particular disease? Palpitations, episodic headache and sweating or diaphoresis. Obviously what comes in your mind? Pheochromocytoma. Workup shows small left-sided suprarenal mass. So you found the tumor also, suprarenal mass. Which of the following would be done for the confirmation? So we are suspecting pheochromocytoma. Right? And for pheochromocytoma, what is the most sensitive screening test? That is 24 hours urinary catecholamines and VMA, vanillyl mandelic acid levels. So since catecholamines are not mentioned, what is the correct answer? Urinary VMA. right? 5 HIAA levels in the urine, not in the blood. It is used for carcinoid syndrome. This is used for carcinoid syndrome. Clear? So correct answer for this question is A. Pheochromocytoma is very, very important, especially the investigations in pheochromocytoma. So first important question, what is the most sensitive screening test? We discussed 24 hours, urinary and catecholamines and VMA level. But if the question is asked, what is the best test for diagnosis, then it is plasma-free metanephrines. Okay, that is for diagnosis. Now see the twist, radiological investigation of choice for diagnosis. So radiological investigation of choice for adrenal pheochromocytoma, extra-adrenal pheochromocytoma, pheochromocytoma in pregnancy, for all of these we go for MRI. If patient is having extra-adrenal pheochromocytoma, MIBG scan is helpful, but the investigation of choice remains MRI. And nowadays they are asking, what is the gold standard investigation for definitive staging? Definitive staging of pheochromocytoma, and we go for PET scan or FDG PET. So these are important points related to investigations in pheochromocytoma. Question number 6, it's an easy question. First, chronic alcoholic female, patient with chronic liver disease. So two problems, patient is chronic alcoholic having chronic liver disease, presents with sudden onset hematemesis. Okay. So what is the problem? In patients of chronic liver disease, what is the problem? These patients have portal hypertension, right? And because of this portal hypertension, what are the two universal manifestations? First, patients are having esophageal varices, and second problem, these patients have splenomegaly. Okay, so whenever the pressure is more than 12 mmHg, there is bleeding, and because of this bleeding, what happens? There is massive upper GI bleeding that leads to hematemesis. Clear? Now see the option. So what is the most likely cause? First, Mallory Weiss tear. In Mallory Weiss tear, there is partial thickness tear involving mucosa and submucosa, where located just below GE junction. Generally, there is history of vomiting, history of retching, but massive bleeding occurs only in 15% cases. So there is history of vomiting, retching, massive bleeding only in 15% cases. Boerhaave syndrome. What is Boerhaave syndrome? This is spontaneous esophageal perforation. Again, for this, there should be vomiting against closed glottis. In this case, there is esophageal perforation. So whatever the vomitus is there, it goes into mediastinum. So it is characterized by macular striate. It is characterized by macular striate. Tell me, what are the components of macular striate? There is thoracic pain. There is vomiting. There is cervical subcutaneous emphysema. Cervical subcutaneous emphysema, right? So these symptoms are not there. So obviously, Mallory Weiss tear is ruled out, Boerhaave syndrome is ruled out. Perforated ulcer. If ulcer is perforated, because of this, there will be peritonitis. So patient will be having signs and symptoms of peritonitis. So obviously it's not there. So correct answer for this question, it is C, that is bleeding esophageal varices. Question number 7. A female patient after laparoscopic cholecystectomy presented with, what is the problem? Cystic duct stump leak. What should be the immediate management? So first you should understand that what is this cystic duct stump leak. See, whenever we are performing laparoscopic cholecystectomy, we are going to apply 2 clips towards cystic duct side and 1 clip towards gallbladder side. After that, we are going to remove the gallbladder. Cut it and remove it. Simple. So what happens? There are 2 clips over the cystic duct stump. Imagine during handling of gallbladder in lap cholecystectomy, some stone slips in CBD, right? If some stone is going to slip in CBD, you are not aware of. So in post-operative period, what will happen? There is increased pressure inside the CBD, and because of this increased pressure, what will happen? The clip will be dislodged and if clip is dislodged, what will happen? There is bile leak. So this is the cystic duct. This is the cystic duct stump, and there is leakage from cystic duct stump. Why? Because there is increased pressure in the CBD because of obstruction. So this is known as cystic duct stump leak. So how you are going to manage? Decrease the pressure. And how you are going to decrease the pressure? You just remove the obstruction. So whatever the obstruction is there, you just remove it. So what is the easiest method to remove the obstruction? Obviously, we will go for ERCP with stenting. So read the question again. Female patient after laparoscopy cholecystectomy presented with cystic duct stump leak. What should be the immediate management? We will go for ERCP with stenting. No need to go for any kind of surgery like Roux-en-Y hepaticojejunostomy or exploratory laparotomy, and we cannot leave patient on conservative management. We have to perform the intervention. Easiest method, remove the obstruction by ERCP and insert the stent. So it is ERCP with stenting. Another question which is very important, it is related to the biliary strictures. So according to Bismuth classification, which of the following is type 3 bile duct stricture? Okay, so Bismuth classification, see, if you see the option 1 here, the injury is here. So the common hepatic duct stump, it is more than 2 cm. So this is type 1. If you see option B, the common hepatic duct stump is less than 2 cm. So this is type 2. Option C, here there is hilar stricture. Can you see? The stricture is at the hilum. So hilar stricture with intact confluence, this is type 3. And if you see option D, here hilar stricture, can you see this confluence? It is destroyed. So hilar stricture with destroyed confluence, that is type 4. So what is the correct answer here? The correct answer for this question is option C. What is type 3? It is hilar stricture with intact confluence. There are two classifications which are important. One is Strasbourg classification and the second is Bismuth classification. Let's discuss Strasbourg classification for laparoscopic bile duct injury. Okay, what is type A? Here you can see type A, we just discussed. This is cystic duct stump leak or leak from subvesical duct of Lashka. Leak from subvesical duct of Lashka, type A, and this is the most common type. What is type B? Here you can see this. This is aberrant right sectoral duct. So here you can see that it is ligation or occlusion of aberrant right sectoral duct, type B. And if there is transaction without occlusion, that is type C. Transaction without occlusion of aberrant right sectoral duct, that is type C. And if there is lateral injury to common hepatic duct, that is type D. What is type E? Nothing. E1 to E5 Bismuth classification. So what is E1? You can see common hepatic duct stump more than 2 cm. E2, common hepatic duct stump less than 2 cm. E3, hilar stricture with intact confluence. E4, hilar stricture with destroyed confluence. And E5, stricture involving aberrant right sectoral duct with or without stricture of common hepatic duct. I am repeating type 5. Stricture involving aberrant right sectoral duct with or without stricture of common hepatic duct. So Strasbourg classification, Bismuth classification, both of these are very important. Question number 9. Another repeat question. It was asked many times. Neuroendocrine tumor of pancreas associated with necrolytic erythema migrans. You will not hear this symptom anywhere else. So this is the most common symptom seen in which tumor? Glucagonoma. Glucagonoma, most common symptom is dermatitis, that is known as necrolytic erythema migrans. So here you can see how it looks like. You can see here there is central necrosis and these are the migratory lesions. So this is known as necrolytic erythema migrans. What is the problem in glucagonoma? There is excessive secretion of glucagon, and because of that the patients are having what? Hyperglycemia. There is dermatitis also. So what is the other name? It is also known as hyperglycemic cutaneous syndrome. It is also known as 4D syndrome. So what are the components of 4D? Diabetes mellitus, dermatitis, DVT, depression. And what is the dermatitis? That is the most common symptom, necrolytic erythema migrans. So if you see the question again, the correct answer for this question is glucagonoma. Question number 10, another repeat question. Best investigation for the diagnosis of gastroesophageal reflux disease. And you know the answer, that is 24 hours pH monitoring. Why? Because the gastric content is going into esophagus, so we go for 24 hours pH monitoring. That's the investigation of choice. In which cases endoscopy plus biopsy is investigation of choice? So you know it is investigation of choice in Barrett's esophagus, Barrett's and carcinoma esophagus. Carcinoma esophagus. In which case manometry is investigation of choice. So motility disorders. This is investigation of choice in motility disorders of esophagus like achalasia cardia, achalasia. And in which cases barium swallow is investigation of choice? Yes, anatomical disorders like Zenker's diverticulum. That is Zenker's diverticulum. So what is the correct answer here? The correct answer is B. The patients of GERD, they have characteristic triad of symptoms. So what are the symptoms? There is retrosternal heartburn, there is epigastric pain, and there is regurgitation. We discussed the investigation of choice or best investigation is 24 hours ambulatory pH monitoring, and we are going to calculate a score. What? Demister score. And what should be the value of this Demister score? In GERD, it should be more than 14.7. Right? For the symptomatic improvement of GERD patient, we give PPI, but the treatment of choice is laparoscopic Nissen's fundoplication. Question number 11, another repeat question. 35 years old male with gastric outlet obstruction. So diagnosis is already given. Presented to emergency with multiple episodes of vomiting. Which of the following fluid is preferred in this patient? Very easy to understand. Imagine this is the patient, and in this patient, what is the age? 35 years. What is the cause? Most common cause of gastric outlet obstruction worldwide, it is carcinoma stomach. But what is the age for carcinoma stomach? 50 to 60 years. Here patient is young, so generally it's because of benign disorder. And what's that? It's peptic ulcer. And where is the location? Generally it is in the first part of duodenum. Right? So there is gastric outlet obstruction. Because of that there is vomiting. So in vomitus there is loss of HCl and there is loss of potassium. Simple. So whenever there is loss of HCl, what happens? H plus loss, there is metabolic alkalosis. Okay. There is hypokalemia. There is hypochloremia. Hypokalemia, hypochloremia, metabolic alkalosis. Okay. Whenever there is persistent vomiting or multiple episodes of vomiting, since in the body there is metabolic alkalosis, in the kidney there is sodium proton exchanger. If there is sodium proton exchanger in the kidney, what? This exchanger is going to preserve H plus and it is going to excrete sodium. So what happens? In such patients, there is hyponatremia and there is a hypovolemia. Why? Because there is loss of fluid in the vomitus. So hypovolemia, hyponatremia, right? So whenever these patients are brought to the emergency, we have to correct sodium. That's why we have to give what? Normal saline. Similar situation is there in children who are having hypertrophic pyloric stenosis. So even in hypertrophic pyloric stenosis, as well as in the patients of gastric outlet obstruction, what is the fluid of choice? Fluid of choice is normal saline. So correct answer for this question is A. So how we manage such patients? First, when these patients are brought to the emergency, the patient should be NPO for 48 hours and we have to give IV fluid. What is the fluid of choice? NS, we discussed, is the normal saline. Normal saline. What is the good thing? That because of ulcer, there is edema. Near pylorus, there is edema. So whenever you don't allow anything orally to the patient for 48 hours, what happens? Edema settles and patient improve. But sometimes there is no improvement. Why? Because there is stricture. And if there is stricture, we can go for truncal vagotomy plus antrectomy. And if antrectomy is not possible because of excessive fibrosis or scarring, then we can go for truncal vagotomy plus gastrojejunostomy. So this is how we manage the patients of gastric outlet obstruction. Question number 12. This question is asked almost every year in each and every paper. Two questions. One, pneumoperitoneum, perforation peritonitis question, and second, tension pneumothorax. These two questions are asked in each and every paper. See the question. Number 12, 34 years old female with history of alcohol intake was taking NSAIDs. She was taking NSAIDs for abdominal pain. She developed severe pain in the whole abdomen. Right? Radiograph is given below. What is the finding in this radiograph? You can see here. What? There is free air under the right dome of diaphragm. So this is a case of pneumoperitoneum, and obviously one history is there that patient is taking NSAIDs. It means it is going to increase the risk of peptic ulcer, and there is perforation. So this is a case of perforation peritonitis. What is the correct answer? Hollow viscous perforation. Okay. Rupture of ectopic pregnancy. In that case, there is obviously the patient is in the state of shock, but there is no pneumoperitoneum. In acute pancreatitis also there is no pneumoperitoneum, and pain is in the epigastrium radiating to left side of back. In perforated liver abscess there are signs and symptoms of peritonitis, but pneumoperitoneum is not there. So correct answer for this question is D. Question number 13, another repeat question. According to the image given below obtained from the stomach of a woman, which specialist is needed along with surgeon? You tell me, what is this? So this is hair ball, and this hair ball was removed from the stomach of a woman. What is the name of this condition? So the name of this condition is trichobezoar. What is the problem with this patient? These patients are having psychiatric disorder of trichophagia. Trichophagia means they eat their own hair. These hair are going to collect in the stomach, and this trichobezoar is responsible for gastric outlet obstruction. So what is the treatment? We have to perform the gastrotomy, means we have to open the stomach and we have to remove the hair ball. After surgical treatment, since the patient is suffering from trichophagia, we have to refer this patient to psychiatrist. So what is the correct answer? C. So in these patients, what is the problem? They have trichophagia. Right? You must be knowing the story of Rapunzel. So what is Rapunzel syndrome? Rapunzel was having long hair. So whenever a patient is having long hair and this in trichobezoar, the hair is reaching up to the jejunum. So if it is present or reaching up to the jejunum, this is known as Rapunzel syndrome. What is the problem? When patients start eating the hair, what there is ulceration, so there is abdominal pain, later there is gastric outlet obstruction. We perform gastrotomy, remove the hair ball, and then refer the patient to psychiatrist. Question number 14, another important question asked almost every year. A patient presented with history of bronchospasm. One thing. Second, tumor was present in the ileum. Second, third clue, increased 5-hydroxyindole acetic acid in the urine. So first, there is bronchospasm. Second, tumor is located in ileum and there is increased 5-hydroxyindole acetic acid in urine. Tell me, these findings are suggestive of which tumor? The tumor which is secreting 5-hydroxytryptamine, also known as serotonin. And whenever there is action of monoamine oxidase, it is converted into 5-hydroxyindole acetic acid, which is excreted in urine. That's how we are going to make the diagnosis of carcinoid tumor. And you know, in carcinoid syndrome, the patients are having cutaneous flushing. There is wheezing, bronchospasm and diarrhea. Bronchospasm, flushing, wheezing, diarrhea, these are manifestations of carcinoid syndrome. So there is tumor plus body is not able to metabolize the excess production of serotonin. That's why there is carcinoid syndrome. So what is the correct answer? It's not neuroblastoma, leiomyoma, it's carcinoid syndrome. So what happens? In carcinoid tumor, there is excessive production of 5-hydroxytryptamine, which is also known as serotonin. and it is metabolized in liver, lungs and brain. Mainly in which organ? Liver. Now see, when the body production capacity exceeds the metabolic capacity, what happens? Yes, there is excess of 5-hydroxytryptamine or serotonin that is responsible for carcinoid syndrome. It is metabolized by monoamine oxidase. So it is converted into 5-hydroxyindole acetic acid, which is excreted in urine. So this is the investigation of choice for diagnosis of carcinoid tumor. So presence of flushing, bronchospasm, wheezing, diarrhea, suggestive of carcinoid syndrome, and investigation of choice for diagnosis is this. If you see the question again, what is the correct answer? Correct answer is A. Again a repeat question. A 23 years old male had acute appendicitis 3 days ago. Patient had appendicitis 3 days ago, now came to emergency department or surgery department with abdominal tenderness. Which of the following incision is appropriate for this condition? Okay. See, if the patient is having acute appendicitis, right, the preferred incision is which one? This is McBurney's incision. The preferred incision is McBurney's incision, right? If both options are there, McBurney's as well as Lange, this one is Lange incision. This was not there in the option. So out of these two, if we have to choose, we have to choose the Lange incision. What is the third incision which is used for appendectomy? This one, this is Rutherford-Morrison incision. Rutherford-Morrison. Okay. Out of these three, the Lange incision and McBurney's incision, these are muscle splitting incision. But Rutherford-Morrison incision, this is muscle cutting incision. So what are the two important points you have to remember? In appendectomy, Lange incision is preferred over McBurney's incision. McBurney's and Lange are muscle splitting incision. Rutherford-Morrison is muscle cutting incision. One thing is clear. Second, if there are signs and symptoms of perforation of appendix, means appendicular perforation. Suppose in the question it was mentioned that patient was having generalized abdominal pain and there was guarding or there was rigidity. Means if the patient is having signs and symptoms of peritonitis, in those cases we are going to suspect the perforation, and if you suspect appendicular perforation, then you should go for this midline incision. Midline incision, right? So certain students were telling me that sir, guarding or rigidity was not mentioned, only abdominal pain is mentioned. So if only abdominal pain is mentioned which is not generalized, go for option number 3, that is McBurney's incision. And if there are signs and symptoms of perforation, then we will go for option number 2, and that is midline incision. That is midline incision. So if we see the language of question number 15, the correct answer will be option number C, that is McBurney's incision. What are the various abdominal incision? This subcostal incision, generally used for open cholecystectomy, known as Cocker's incision. This paramedian incision, this is the transverse incision performed for malignancies. Most commonly used is midline incision for perforation peritonitis. We discussed for appendectomy, McBurney's, Lange and Rutherford-Morrison incision. Since the space is not there on the right side, that's why it is indicated here. So it is here. We extend the incision upward and laterally, muscle cutting incision. And you know that in gynae, especially for cesarean, this phalangeal incision is done, right? So these are important points related to incisions. Question number 16. What is the diagnosis based on the given image of a newborn? So first you tell me, what is this investigation? Here we are putting a coin over the anus, expected anus or expected anal dimpling, and we put this child or this neonate in upside down position minimum for 3 minutes, so that the gas is going to rise. We put a coin and we are going to measure the distance between this gas bubble and the coin, right? What is the name of this investigation? This is invertogram. After how much time we are supposed to perform the invertogram? It is performed after 6 to 12 hours of birth. You have to remember this because this is a question. Invertogram is performed after 6 to 12 hours of birth. How it's done? You have to put a coin over the expected anus or anal dimpling and then put the baby in upside down position minimum for 3 minutes so that the gas is going to rise in the rectum or in the anal canal. And then we measure the distance between this gas bubble and this coin. Whenever the distance is more than 2 centimeter, we suspect high lesion. Means if the gap is more, it means the abnormality is in the proximal part of rectum. Right? So this is invertogram. So for which particular condition it is done? It is done for anorectal malformations. So what is the correct answer here? Imperforate anus. So this is invertogram, which is performed for imperforate anus. What are the two details you have to remember? First, it is done after 6 to 12 hours of birth, and you have to put the baby in upside down position minimum for 3 minutes. Measure the distance between gas bubble and the coin. Question number 17. Patient presented to hospital with increased frequency of micturition. So first detail is there is increased frequency. Okay. On cystoscopy, pale ureteric orifice was seen. Bladder images given below. What is the most probable diagnosis? Okay. Now, frequency, increased frequency is seen in cystosomiasis also, bladder tuberculosis also. Increased frequency is the earliest, most common symptom of both cystosomiasis as well as bladder tuberculosis. It is also seen in malakoplakia, but along with increased frequency, there is urgency and there is hematuria. There is urgency as well as hematuria. Okay, so there is no mention of hematuria. Now, what is the symptom in carcinoma bladder? You know that there is painless, gross hematuria, and it is intermittent. So it is painless, gross, intermittent hematuria. And what is the age? Generally, it is seen in 60 years, approximately 60 years of age. So hematuria is not mentioned, so this option is ruled out. Increased frequency is there. Now, what is the earliest finding on cystoscopy in tuberculosis? There is pallor around ureteric orifice. And after that, there is fibrosis in the bladder. So the bladder becomes small and contracted. That's known as thimble bladder. So in tuberculosis, there is increased frequency. There is pallor around ureteric orifice and there is small contracted bladder or thimble bladder. Here you can see the bladder is small and contracted. So see the changes. Here you can see the pallor around ureteric orifice on which investigation? Cystoscopy in bladder tuberculosis. There is formation of these tubercles, and because of these tubercles there is chronic inflammation. After that there is fibrosis. So here you can see there is small contracted bladder. If you see the ureteric orifice, it looks like golf hole. So there is golf hole ureteric orifice. Golf hole ureteric orifice, and here you can see the small contracted bladder. It looks like thimble, so that is thimble bladder. So in the question, what is the correct answer? It is bladder tuberculosis. What happens in cystosomiasis? Here also there is chronic inflammation, and after that what happens? There is bladder calcification. So there is bladder calcification, and you know that cystosomiasis is the most common cause of bladder calcification. Afterwards, because of chronic inflammation, it is going to increase the risk of both squamous cell carcinoma as well as transitional cell carcinoma. The risk is more for squamous cell carcinoma. Clear? So correct answer for this question is what? Bladder tuberculosis, because there is pale ureteric orifice and small contracted bladder. Question number 18 is very easy. You can see there is fistula. This is bladder and this is vagina. So between bladder and vagina, there is communication. What is fistula? It is the communication between two epithelium lined surfaces. So what is the name? Bladder and vagina. So vesico-vaginal fistula. Correct answer is B. It is vesico-vaginal fistula. Question number 19. Totally new question, a bit difficult for you people. Chemotherapy was given for bladder cancer. For which drug the dose should be reduced if radiotherapy is given? So first question, that what is the chemotherapy regimen we give in the carcinoma bladder? This is MVAC. What's that? M means methotrexate. V means we give vinblastine. That's vinblastine. You tell me A. A is adriamycin. Adriamycin. And C, you know, cisplatin. Cisplatin. So this is platinum based chemotherapy, MVAC. This is the most commonly used chemotherapy regimen. Nowadays, we can give low dose gemcitabine with concurrent radiotherapy, and the response is almost comparable to this chemotherapy, right? So what is mentioned in the question, that for which drug the dose should be reduced if radiotherapy is given. So we have to give gemcitabine. For this question, the correct answer is B. What is written in the literature, that low dose weekly gemcitabine with concurrent radiotherapy is a tolerable regimen which have comparable outcomes with platinum based combined treatment. What was the regimen? MVAC. Clear? So if you see the question again, low dose and chemotherapy is given and radiotherapy is also given in this patient. So correct answer for this question is B, that is gemcitabine. Question number 20. Which of the following is used for prostate cancer? Again, it's a repeat question. Obviously, it's the Gleason grading and Gleason score which is used for prostate, right? You tell me, this Bethesda score, it is seen for, or it is used for thyroid nodule FNAC. So thyroid nodule FNAC, we use Bethesda. Alvarado, which is also known as Mantrel score, and it is used in acute appendicitis. Acute appendicitis, right? You tell me this Nottingham score. So this is for grading of breast cancer. Nottingham score, it is used for grading of breast cancer, right? So what is the correct answer? The correct answer for this question is A, that is Gleason score. In urology, certain named staging and gradings are asked. Also, there is Robson staging and there is Fuhrman grading. Robson staging, Fuhrman grading, this is used for RCC. We discussed Gleason grading and Gleason score, that is for carcinoma prostate, and there is Jackson staging. Jackson staging, and this Jackson staging is used for which malignancy? It is used for carcinoma penis. So Robson, Jackson, Gleason, these are for urological malignancies. Question number 21 is a new question. Which of the following iodine isotope is used in the management of prostate cancer? See, for localized prostate cancer, we give brachytherapy. This question was asked in NEET PG. We use brachytherapy for localized breast cancer. And what are the permanent implants used? The mnemonic is IPC. For brachytherapy, the permanent implants used are IPC. I means iodine, so this is iodine 125. P means palladium, palladium 103. This is palladium 103. And C, that is cesium. So this is cesium 131. You have to remember. These are the permanent implants used for brachytherapy. Iodine 125, palladium 103 and cesium 131. These are the most commonly used implants. You got it? So what is the correct answer? For this question, the correct answer is C. That is iodine 125. See what is written in Campbell Urology 11th edition. Brachytherapy has become popular for the treatment of patients with clinically localized prostate cancer. And the most commonly used permanent implants, can you see here? Iodine 125, palladium 103 and cesium 131. See question number 22. Similar questions has been asked continuously for the last 2 to 3 years in INI-CET, NEET PG as well as FMGE. What is the name of this investigation? So what you can see here, the dye is being injected from anterior urethra and it is going to this part of posterior urethra. Little amount of dye you can see in the bladder. So if you inject the dye against the flow, that is retrograde, along the flow, that is antegrade. So what is the name? This is retrograde urethrogram, also known as RGU. Retrograde urethrogram, RGU, it is preferred for visualization of, you tell me, anterior urethra or posterior urethra? So obviously anterior urethra. Correct answer is RGU. B. How MCU looks like? So see here, the labeling of RGU, from the tip of penis, the dye is being injected. So this is the meatus, this part is penile urethra. Here you can see the bulbar urethra, this part is membranous, this is prostatic urethra, and you can see the dye in the bladder. See the comparison of RGU and MCU, how to differentiate. In RGU, you are injecting dye from below. So the dye reaches bladder and there is little amount of dye in the bladder. In MCU, that is known as micturating cystourethrogram, we inject the dye into bladder. So the maximum amount of dye will be in the bladder. So if you compare RGU MCU, there will be little amount of dye in bladder and the maximum amount will be there in MCU. MCU is preferred for visualization of posterior urethra. RGU is preferred for visualization of anterior urethra. So if a question is asked, what is the investigation of choice for diagnosis of anterior urethral strictures? For anterior urethral strictures, yes, so that is RGU. And what is the investigation of choice for diagnosis of posterior urethral strictures? Posterior urethral strictures, so that is MCU, right? Apart from diagnosis of posterior urethral stricture, it is also used for diagnosis of posterior urethral valve and VUR. So posterior urethral valve as well as VUR. How IVP looks like? So here you can see intravenous pyelogram, you can see the outline of kidney, the dye is going into the ureter. So what you can see, bilaterally ureters are dilated, there is hydroureteronephrosis, and you can see the terminal part of ureter is cystic and dilated. So this is bilateral ureterocele. So this is intravenous pyelogram. So if you see the question again, what is the name of investigation? That is RGU, retrograde ureterogram. Question number 23. 14 years old boy is presented with absent left testis in scrotum. Absent left testis in scrotum. On examination, where is the left testis? It is in superior inguinal pouch, right? So testis location is abnormal. What is the problem? Here, the location of testis is abnormal. And if some location is abnormal or there is some abnormal development, that is known as ectopic. Location is abnormal, so there is ectopic, right? Now, how to differentiate undescended testis from ectopic testis? In undescended testis, there is abnormal development as well as abnormal location. But the testis will be located along the path of descent, either in the inguinal canal or in the abdomen or near superficial ring or near deep ring, right? This is the normal path of descent. If some other location is there, that is ectopic. What is retractile testis? See, in retractile testis, the location is also normal and the development is also normal. Location as well as development, both are normal. It is retractile, means it moves to and fro from scrotum to groin. Retractile, it moves to and fro from scrotum to groin, and cryptorchidism is nothing, it is also known as undescended testis. So you got it? Abnormal location is there, which is not in the path of descent of testis. So correct answer for this question is C, that is ectopic testis. So we discussed what are the important points, that in ectopic testis there is normal development but there is abnormal location. So there is normal development till inguinal canal, and after that, because of abnormality of gubernaculum, it goes into the groin. Where? What is the most common location? This is frequently asked. It is superficial inguinal pouch. So this is the location here. Superficial inguinal pouch. That's the most common location of ectopic testis. And what about retractile testis? We discussed that in retractile testis there is normal development, there is normal descent also, but testis moves back and fro between scrotum and groin. Why? Because in these patients there is overactive cremasteric reflex as well as there is increased tone of cremasteric reflex. Question number 24. A 35 years old male came to OPD with swelling in, there is swelling in left scrotal region and pain. Pain increased on standing. Pain increased on standing and in the evening. On palpation, it feels like bag of worms. What is the most likely diagnosis? Okay, see, if you see the diagram here, you can see that the swelling is located on the left side, and by looking at the swelling, you can see that it looks like that there are bag of worms. So patient is also describing bag of worms like feeling, and this is classically or typically seen in the patients of varicocele. What happens? The characteristic feature, whenever a patient is going to lie down, the swelling decompresses and it becomes prominent on standing. Why especially in the evening? Because if there is prolonged standing, patients are usually working somewhere. So they are standing for long period, and in the evening patient is going to complain of pain. Typical feature. Okay. So correct answer here, it's varicocele. The characteristic feature, what? It is more common on left side, bag of worm-like sensation. Why not testicular torsion? In testicular torsion, there is acute history and there is severe agonizing pain. It is not related to what? Posture. Epididymal cyst, there is no relation with posture and there is well-defined swelling. No bag of worm-like sensation. Femoral hernia, what happens? The location is not here. This is not the location of the femoral hernia, and again in femoral hernia, there is no bag of worm-like sensation. So correct answer for this question is A. You know that varicocele is generally seen in patients who are tall and thin. So tall, thin adults, right? It is more common on left side. Initially patients complain of discomfort and later they complain of swelling, and they tell you that, sir, swelling decompress spontaneously on lying down position, becomes more prominent on standing. And if there is high grade, in that case, high grade of varicocele, in that case you can have this bag of worm-like sensation. So this is varicocele, and this is the surface appearance of varicocele. Question number 25. A patient presented with history of intermittent claudication. If there is history of intermittent claudication, it means it is because of muscle ischemia, and muscle ischemia is because of what? Yes, arterial occlusion or arterial narrowing. Initially, he used to walk for 400 meters without pain. He used to walk for 400 meters, but now after walking for 200 meters, he develops the pain. So what? The walking distance has been reduced. Now it's 200 meters only. Pain was exaggerated by lying down and improved by hanging the legs by the side of bed. What is the most probable cause? So this is the typical history of Buerger's disease. Typical history of Buerger's disease, which is also known as thromboangiitis obliterans. What happens? There is involvement of medium and small sized vessels, and these patients have intermittent claudication. Initially, patient used to walk for certain distance. Then patient will tell you that, sir, whenever I start the walk, there is pain, but I continue the walk and pain disappears. Then he says that, sir, I can walk with the pain. Then pain compels me to the rest, take rest, and in grade 4, what? Patient tells you that, sir, I'm having rest pain. Okay. So this is the typical history of Buerger's disease. What happens in rest pain? If patient is going to lie down, what? There is cutaneous ischemia, because of that there is pain. So in the night, patient is hanging the legs by the side of bed. So because of gravity, some blood is going to the ischemic areas and there is partial or some kind of relief patient is going to feel. Clear? So this history, that it was exaggerated by lying down, improved by hanging the legs by side of bed, it is suggestive of what? Rest pain. So the diagnosis is Buerger's disease and there is rest pain. Neurogenic claudication. What is neurogenic claudication? Generally, these patients have lumbar canal stenosis. So apart from claudication, these patients have tingling and numbness, right? The pain will be there on walking also, and even if the patient is standing still, there is pain. It's not seen in venous claudication. In sciatic pain, obviously there is compression of sciatic nerve, so there is tingling and numbness. So correct answer for this question is what? C, rest pain, and this patient is having thromboangiitis obliterans, that is also known as Berger's disease. See the question number 26. A female patient during washing clothes in cold water. She was washing the clothes in cold water. Exhibit color changes of her hands. And what was the color change? From white to red. Which of the following drugs is best suited for this patient? So first of all, what is this condition in which after using some vibrating tools or after immersing your hand or fingers in cold water, what happens? There is certain color change. And what's that color change? There is blanching, then there is cyanosis, and then there is redness. Blanching means whiteness, then there is cyanosis, and then there is redness. This is Raynaud's phenomena. So this is Raynaud's phenomena, right? You know that this Raynaud's phenomena, it is more common in females. Second, it is more common in fingers than toes. More common in fingers than toes. Simple. Now, what is the advice which should be given to the patient? In more than 90% patients, there is improvement if patient is going to avoid the stimulus. We ask the patient that don't use some kind of vibrating tools. You should not put your hands in the cold water. During winter times, you can use gloves, something like that, right? Even after avoiding stimulus, if there is no improvement in these patients, we give calcium channel blockers like diltiazem, like nifedipine. So what is the correct answer? This is calcium channel blockers. See what's the pattern of color change. After stimulus, what happens? There is spasm of arterioles, and because of this spasm, there is local syncope, and that's why the color is white. So there is blanching. After that, what happens? There is dilatation of capillaries and venules. Because of that, there is collection of deoxygenated blood. So there is cyanosis or bluish appearance. After that, what happens? There is resolution of digital spasm, means recovery is there, and then there is redness. So it is blanching, cyanosis, redness. It is more common in fingers than tongue. And if you see the pulses are normal. Radial pulses, ulnar, pedal pulses, these are normal. So what is the management for these patients? We advise that avoid the stimulus, and if even after avoiding the stimulus there is no improvement, then we advise calcium channel blockers. Which one? Diltiazem and nifedipine. Question number 27, again a repeat question. A chronic smoker, thin male, suddenly collapsed and brought to the emergency. Chest x-ray image is given below. What is the next step of management? You see the x-ray and tell me what is the diagnosis. First, see the diaphragm. So if you see the diaphragm, see the level. What? On the left side, there is depressed diaphragm. On the left side, there is depressed diaphragm, and simultaneously you can see that there is no bronchovascular markings. Here you can notice that the ipsilateral lung is collapsed. So collapsed lung, no bronchovascular markings means there is pneumothorax, there is depressed diaphragm, there is shift of mediastinum to contralateral side. So what is the diagnosis? Yes, you are correct. This is tension pneumothorax. This is tension pneumothorax. And if you suspect that any patient who is having tension pneumothorax, what is the first step which should be done? Only on the basis of suspicion, put a wide bore needle. So where to put the wide bore needle? In children, second intercostal space in mid-clavicular line, and in adults, in fifth intercostal space in anterior axillary line. Put a wide bore needle in second intercostal space, in children, in mid-clavicular line, in adults, fifth intercostal space in anterior axillary line. And what is the treatment of choice? It's the ICD insertion, intercostal drain insertion in fifth intercostal space in triangle of safety. So what is the correct answer here? The correct answer for this question is A. One of the characteristic feature how you are going to recognize tension pneumothorax and chest x-ray, that there is depressed diaphragm. Second, obviously the ipsilateral lung will be collapsed and there will be shift of mediastinum to the contralateral side. So we discussed we should insert a wide bore needle in children in second intercostal space in mid-clavicular line, adults fifth intercostal space in anterior axillary line according to ATLS update. And the treatment of choice, it should be inserted ICD insertion where? In the fifth intercostal space in anterior axillary line, and in which triangle? Triangle of safety. Question number 28 is an easy question. On this chest x-ray, what you can see that yes, there is blunting of left CP angle, costophrenic angle, and the lung appears collapsed. Why? Because there is collection of fluid. So what is the diagnosis? Is clear-cut case of pleural effusion. So this is pleural effusion. Question number 29. A 50 years old male, chronic smoker, ages 50 years, came to OPD with cough, dyspnea, difficulty in swallowing. Okay. Palpable lump was present in the neck. So there was palpable lump in the neck, might be some lymph node. Smokers are most likely to develop which of the following? Right. Now first you tell me, cough, you know that cough is the most common symptom of carcinoma lung. Most common symptom it is cough, followed by dyspnea, followed by chest pain, followed by hemoptysis. Cough, followed by dyspnea, followed by chest pain, followed by hemoptysis. In smoker, what is the most common type of carcinoma lung seen? Yes, it is squamous cell carcinoma, right? And what is that nodule or lump in the neck? It might be some lymph node. So if you see, smokers are most likely to develop which of the following malignancy? It is squamous cell carcinoma. Apart from squamous cell carcinoma, there is another malignancy which is more common in smoker, and that is small cell carcinoma lung. It's the small cell carcinoma lung. Simple. So what is the correct answer for this question? Smoker, there is cough, dyspnea, difficulty in swallowing. So the most common malignancy seen in smokers is squamous cell carcinoma lung. What are the other special features of squamous cell carcinoma lung? That these are central malignancies, more common in smoker. Apart from that, there is necrosis and cavitation. And this is the most common type of carcinoma lung in India. There is increased secretion of PTHRP. And because of increased secretion of PTHRP, what happens? These malignancies are associated with what? Hypercalcemia. These are associated with hypercalcemia. Question number 30. Again, it's a repeat question. Graft in CABG with long-term patency. So for long-term patency, which grafts are better? Obviously, arterial grafts are better and natural grafts are better than synthetic. So two principles for long-term patency. Arterial grafts are better than venous grafts. Natural grafts are better than synthetic. So first you have to choose the natural. And in arterial and venous, which one? Arterial. So which artery? It is left internal mammary artery which is preferred. So it is LIMA, left internal mammary artery, which is the most preferred vascular graft for coronary artery bypass grafting. So here you can see how CABG is done. Here is the occlusion, right? And we have to bypass the occlusion or obstruction. So this is the left internal mammary artery graft, and this left internal mammary artery graft is going to bypass the occlusion. It's an artery, so it's better. So this is the most preferred vascular graft. Whenever two or more than two vessels are occluded, we are using CABG, or we are going for CABG, coronary artery bypass grafting. What is the good thing about long saphenous vein? It is long saphenous vein, so it is having extra length. So most commonly used graft for CABG is long saphenous vein. So two questions. Most preferred graft, that is LIMA, left internal mammary artery. Most commonly used graft, that is long saphenous vein because of extra length. So if you see the question again, what is the most preferred graft even in terms of long-term patency? That is internal mammary artery. Why arterial grafts are better than venous? Because arterial grafts are having non-collapsible lumen and the venous grafts are having collapsible lumen. So because of this collapsible lumen, what happens? There is increased risk of thrombosis, occlusion. So arterial grafts are better than venous. Correct answer for this question is A. Question number 31. A burn patient was brought to the emergency with involvement of whole back, posterior aspect of neck and the gluteal region. Which of the following is preferred treatment pattern? So first you tell me, what is the most common cause of early death in patients of burns? Early death, and the most common cause of early death, that is hypovolemia. hypovolemia, or that is hypovolemic shock. It's the hypovolemic shock, right? So in this patient, first we have to go for resuscitation. After that, whatever the burnt skin is there, we can go for the grafting. What do you mean by isograft? Whenever the graft is taken from identical twins, that is isograft, and whenever it is taken from same species, that is allograft or homograft. Clear? So let's see the options one by one. Option number A, resuscitation followed by isograft or allograft. This is correct. Resuscitation followed by healing by secondary intention. We are not going to keep the wound open. Debridement and excision of burnt skin followed by resuscitation. No. First step is resuscitation. And D, only debridement of burnt skin? No. So correct answer for this question is A. First we have to go for resuscitation, and then we have to cover the burnt skin either by isograft, allograft or autograft. Even patient skin can be used. So correct answer for this question is A. Question number 32, again an indirect repeat question. Split thickness skin graft for wound closure on the thigh includes. So why it is known as split thickness skin graft? Because it includes epidermis plus part of dermis. So in split thickness skin graft, we include epidermis plus part of dermis. So correct answer for this question is B. So there are two types of skin graft. One is known as split thickness skin graft, also known as Thiersch, and the second is full thickness skin graft known as Wolff's. In split thickness, we take epidermis plus, you can see here, plus part of dermis. And if we are going for full thickness skin graft, in that we take epidermis plus full thickness of dermis. Okay, so full thickness skin graft is known as Wolff's. Split thickness skin graft is known as Thiersch. So correct answer for this question is B. Grade of glioblastoma multiforme, again a repeat question. What is grade 1? This is pilocytic. This is also asked frequently. And what is grade 4? Glioblastoma multiforme. These are two frequently asked questions. You know, pilocytic astrocytoma is the most common type of astrocytoma in children, having best prognosis. Glioblastoma multiforme is the most common type of astrocytoma in adults, having worst prognosis. See the WHO classification. So grade 1 is pilocytic. What is the good thing about this? That pilocytic astrocytoma doesn't infiltrate the surrounding brain. That's why resection is sufficient. Grade 2 is low grade. Grade 3 is anaplastic. Most malignant, overall most common type in adults, that is grade 4 glioblastoma multiforme. It is having worst prognosis. And what is the pathological characteristic feature? There is endothelial proliferation plus necrosis. So if you see the correct answer, glioblastoma multiforme, it is D, that is grade 4. Question number 34. In an old patient after complete excision of glioblastoma, what should be done next? Right? So another question, what is the treatment actually? We have to go for cytoreductive surgery. Cytoreductive surgery means maximum amount of tumor should be excised. What is the feature of astrocytoma? That it is going to infiltrate the surrounding brain. So we have to go for external beam radiotherapy. So after surgery, we have to go for radiotherapy. So correct answer for this question is B. Even we can give temozolomide. But temozolomide is given for newly diagnosed glioblastoma multiforme and for recurrent glioblastoma multiforme. This is not given in all cases. Temozolomide is given to both patients of glioblastoma multiforme and oligodendroglioma. So if we have to choose between temozolomide and radiotherapy, this is a preferred option. Nothing to be done, no chemoradiation, no. So after surgery, we go for external beam radiotherapy. So correct answer for this question is B. So see here how we are going to manage the patients of glioblastoma multiforme. We have to go for cytoreductive surgery followed by external beam radiotherapy. And for malignant gliomas, we use carmustine cisplatin. Temozolomide, it is used in glioblastoma multiforme, oligodendroglioma, which glioblastoma multiforme which is newly diagnosed or patient is having recurrent glioblastoma multiforme. Question number 35. Which of the following drug is preferred for lowering of uric acid to prevent renal damage in tumor lysis syndrome? So first of all, you should understand that what are the various dyselectrolytemias seen in tumor lysis syndrome. So what happens in tumor lysis syndrome, there is rapid breakdown of cells, so there is rapid turnover of nucleic acid. So what will happen, hypoxanthine will be converted into xanthine and xanthine is converted into uric acid. We can use allopurinol, but the better drug is rasburicase. This is recombinant urate oxidase which you can use. Because of intracellular release of potassium, what is the problem? Patients are going to develop hyperkalemia. Because of that, there is increased risk of arrhythmia. There is release of intracellular phosphate. It means patient will be having hyperphosphatemia, and this hyperphosphatemia will be, it means increased phosphate will combine with calcium. So what will happen? Patient will develop hypocalcemia. So there is hyperphosphatemia, there is hypocalcemia. This calcium phosphate is deposited in the renal tubules, and because of that, what's the problem? There is increased risk of renal failure. So how we can prevent renal failure? We can go for aggressive hydration. In severe cases, we should go for hemodialysis also. In tumor lysis syndrome, there is deranged oxidative metabolism, and that's why patients are having lactic acidosis. So first, what are the dyselectrolytemia seen? Hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, there is lactic acidosis. For lactic acidosis, we can give sodium bicarbonate. Renal failure we discussed. For hyperuricemia, you can use allopurinol or rasburicase. This one is preferred. Right? Now see the question. So which of the following drug is preferred for lowering of uric acid to prevent renal damage in tumor lysis syndrome? It's not furosemide, it's not allopurinol. Preferred one is B, that rasburicase. Correct answer is B. Question number 36. This is not the exact image which was given. See the question. What is the next management for this type of injury given in the image after 3 days of RTA? And the image which was given in the exam, in that there was necrotic muscle, there was visible bone, visible external genitalia, and the Foley's catheterization was done. So after 3 days of this extensive trauma, necrosis was there. It means the patient, most probably patient was having what? Necrotizing fasciitis. Right? In such situations, what we have to go for? We have to go for extensive debridement. Right? And after that, you cannot close it. So for improving the healing of the wound, we give what? Hyperbaric oxygen. So one by one, we are going to discuss the option. Debridement of necrotic tissue with primary closure, you cannot close if there is presence of necrotic tissue. So we have to go for debridement. Debridement of necrotic tissue with hyperbaric oxygen, yes, because it fastens the wound healing. Amputation, no, straight away you are not going for amputation. Clean and close with rotation flap, no. We are not going to close because there is presence of necrotic tissue. So by using principle of exclusion also, you can solve this question. And what is the correct answer for this question? It is B. GCS score of RTA patient was 10. What is the severity of injury? So how much is the score in mild traumatic brain injury? It is 13 to 15. GCS 13 to 15. In moderate traumatic brain injury, it is 9 to 12. And in severe, it is less than equal to 8. Right? So here it is 10. So what is the correct answer? It is moderate traumatic brain injury. You must be knowing that GCS varies from 3 to 15, mild is 13 to 15, moderate 9 to 12, and the severe traumatic brain injury, the score is less than equal to 8. Question number 38, a new question. After emergency tracheostomy outside the hospital, patient developed surgical emphysema. Surgical emphysema is one of the common complications of tracheostomy. What is the most probable reason? Why surgical emphysema occurs? Generally, if we are going to apply the tight suture around the tube or tight packing material around the tube, so what happens? There is extravasation of air into subcutaneous tissue. Rarely we are going to injure the posterior wall of the trachea. Then also there is surgical emphysema, but that's a rare cause. Common causes are tight packing material, use of tight suture around the tube, that can lead to surgical emphysema. So in patients of tracheostomy, what are the common causes of subcutaneous emphysema? First, tight closure of tissues around the tube, or we are using tight packing material around the tube, then also there is increased risk. Or if you are going to insert the tube and there is creation of false passage into pretracheal tissues, these are the common causes. You might injure the posterior wall of trachea and that can lead to subcutaneous emphysema, but that's a rare cause. So see the question again. After emergency tracheostomy outside the hospital, patient developed surgical emphysema. What is the most probable reason? It's the rare cause. Blockage of tube can lead to emphysema, rare cause. Tight suture, this is one of the common cause. So correct answer for this question is D. Question number 39. What is not a component of splenic trauma based on AAST grading? So you know what we are going to include in AAST grading. So this is AAST grading of splenic trauma. What you can see that there is hematoma, you can see there is capsular tear, you can see what there is laceration, you can see what there is devascularization, shattered spleen. So we include hematoma, we include parenchymal destruction or injury, we include laceration, we include vascular injury, but adjacent organ involvement is not included. So the question, parenchymal destruction included, vascular involvement included, hematoma, laceration included, adjacent organ involvement is not included. So correct answer for this question is C. Question number 40, again a repeat question. Which method is best for hair removal for surgery? Right? Means which method is having least risk of infection? So best method is on-table clipping. On-table clipping followed by on-table use of depilatory creams. Okay, followed by on-table use of razor. On-table clipping followed by on-table use of depilatory creams followed by razor. Why razor? Use of razor is associated with increased risk of infection, because whenever you are using razor there are minor cuts, and because of minor cuts in the skin there is increased bacterial growth and increased risk of infection. Simple. So what is the correct answer? Hair removal by razor in the evening before surgery? No. Hair removal before surgery by use of depilatory creams? No. On the OT table by clipper? Yes, it's correct. D, on the OT table with razor, incorrect. So correct answer for this question is C. There are many questions which are asked in relation to prevention of wound infection. So what is the most important factor? Hand washing. So whenever you are going to attend any patient, after attending that patient, wash the hands. Means wash your hands between the two patients. Now hair removal prior to surgery, and what is the best method? We discussed on-table clipping followed by use of depilatory cream followed by razor. Use of prophylactic antibiotics. So what is the best time? The best time is at the time of induction. So at the time of induction you should give antibiotics, or it should be 30 to 60 minutes prior to surgery. And if both are there in the option, what you have to choose? 60 minutes prior to surgery. Part preparation. After that you have to clean that, and ideal OT parameter should be maintained. So these are the factors which are going to prevent the wound infection. Important factors preventing the wound infection. Most important is hand washing. Question number 41. Which advice will you give to the female patient before laparoscopic surgery? Eat full before surgery? No. We ask the patient to be NPO for at least 6 hours. Nil per oral 6 hours, and patient can take clear fluid 2 hours before surgery. 2 hours before surgery. Okay. So NPO at least for 6 hours, and clear fluid can be taken up to the 2 hours before surgery. So eat full before surgery? No. Drink plenty of water before surgery? No. Enema in night before surgery? Not recommended in laparoscopic surgery in all patients. NPO for specific hours, and if the duration is asked, on an average it is 6 to 8 hours. So what is the correct answer? Correct answer for this question is D. Question number 42. Which deficiency occurs after this surgery? So first you tell me what is this surgery. This is Roux-en-Y gastric bypass. Here you can see this is the part of stomach. This part of stomach is bypassed. So this is Roux-en-Y gastric bypass, RYGB. This is most commonly performed bariatric surgery worldwide, RYGB. What is the problem in RYGB? There is impaired gastrointestinal absorption of copper. So these patients are going to develop copper deficiency. Copper deficiency. You can rule out the options. Vitamin D. Vitamin D deficiency can occur, but it's not very common. Why? Because in the proximal part of jejunum, fat absorption can occur. So fat soluble vitamin deficiency is generally not that common. Protein calorie malnutrition, since it is bariatric surgery, obviously it is done to reduce the weight. So malnutrition means obviously protein and calorie will not be absorbed that much. So this is not the answer. Calcium absorption occurs in duodenum and mainly in the proximal part of jejunum. So obviously it's not going to occur. So what kind of deficiency is seen in Roux-en-Y gastric bypass? It is the copper deficiency. So correct answer for this question is D. Question number 43. Family member is volunteering for blood donation for a person with RTA. All of the following are tested before blood transfusion except. Similar question was also asked in INI-CET this year. This was the question in INI-CET. So if you see UK, in UK, for blood transfusion, the screening is done for hepatitis B virus, hepatitis C virus, HIV 1 and 2 and syphilis. Apart from these, in India, it is also done for malaria. Okay, so see the question, it is done for hepatitis B, for C, HIV 1 and 2, it is not done for hepatitis A virus. So correct answer for this question is A. Tumor cells secrete various hormones, chemicals, which can affect various functions in the body. What is it called? So this is known as paraneoplastic syndrome. So the symptom is not dependent on the location of tumor. It is because of production of some active substance or hormone. So that is known as paraneoplastic syndrome. What Robbins says about this paraneoplastic syndrome? So some cancer bearing individual develop signs and symptoms that cannot readily be explained by anatomic distribution of tumor, by the elaboration of hormones indigenous to tissue from which tumor arose. These are known as paraneoplastic syndromes. So correct answer for this question is A. So total number of questions in this FMGE June 2022 from surgery was 44. Some of the questions were integrated, some of the questions were overlapping also. I hope you did well in the exam. All the students who are preparing for the exam, let me tell you, tomorrow's success depends upon today's performance. So if you are working hard, if you are studying on daily basis, definitely you will succeed. Good luck for your exams.